Good evening, everybody. Welcome to our ESID Grand Rounds webinar. Today's topic, as you already know, is only a single disease. It is the treatment and all aspect of APDS, activated PI3 kinase delta syndrome. So I hope you will enjoy. As you see, we have several panel members, which I would like to introduce to you. So I myself work in Prague in Department of Immunology. Actually, you see all our biographies on the web, so I will not go into details. I am involved with APDS mostly since the discovery of the disease with a cohort of patients, and we also participate in some clinical studies. And so do Dr. Bloomfield, who is the pediatric immunologist, also working in our department, and she will start our session with presentation of case reports. And then we invite Sven Krecker, who is the scientist who works at Institut Imagine in Paris, and who was with APDS since the real beginning and participated in the early studies and discovery of the disease, as is still very active since. So welcome, Sven. And the next one will be Anita Chandra. She is the clinician working at Cambridge University Hospital, and she is also very deeply involved in the APDS. And we have already got some questions from you, and many of these questions go to Anita. They are on the clinics and treatment. So Anita, you will have a very busy evening today. And the last entry is by Dr. Maria Elena Macari. She is medical doctor and immunologist interested in immune deficiencies. And since she is in the University of Freiburg, she started to work on APDS registry. And this is the level 3 ESID registry, and we would like to share it with you. And actually, today's webinar is a little bit atypical because after these sessions, we will have another meeting, APDS Registry Investigators meeting, led by Stefan Earl, and it is the cooperation with ESID Registry Working Party. So this is an overview of today's evening. And I think I also want to share with you some of my introduction. Can we move to another slide? Yes, I did not want to do any introduction today, but then I went to PubMed to look for updates and to search what is new. And I realized that the history of the disease somehow lays in front of my eyes because it's not so long. It's actually less than 10 years since the discovery of the disease. And when I saw it, I could not resist to share the timeline with you. So as you see, 2013 and 2014, it was the discovery of APDS 1 and 2. And shortly after that, the publications start to appear with the description of first cohorts. And then in 2017, another papers on pathogenesis and abnormalities in the immune system started to show up, and soon advances in therapy and outcomes of clinical trials. And just now we have really a number of publications on the understanding. Cohorts are getting large. And the last one I was really pleased to find out, it's the publication describing the outcome of transplantation. Okay, next slide, please. I cannot move it. Yeah, I have some background sounds showing all the rest of these publications. So you see these are on discovery and pathogenesis. There are many of them, as I already said, on B-cell defect and T-cell defect, and also the new ones, they are describing altered signaling and metabolic changes. And I am also pleased about this metabolic because this is an important pathway for PI3 kinase, and we will see probably more about that. Yeah, and I have two more slides, very similar ones. Yeah, this is the same system for clinics, and on the right side you can see here the growing number of patients. Actually, some of these publications really receive many citations, and I believe we will discuss all that in the discussion session. And the last one is in therapy. And the same story, there are articles describing natural cause of the disease, mTOR inhibition, specific PI3K delta inhibitions, and the last one is on transplantation. So I think it was really short for introduction. I was actually impressed how short is the history of the disease and how many we already know. And I believe we will discuss this today. And now I will just pass the word to Marketa, and she can start with her case reports.
Good afternoon, everybody. It is my pleasure to set the scene for today's ESID Grand Rounds on APDS with introducing some clinical cases that I hope will be illustrative for our point. So I don't now seem to be able to move the slides. Okay, I have quickly nothing to disclose here. And with that, allow me to introduce you a 6-year-old boy who came to our clinic. He was brought to us by two parents who both claimed they are healthy. The mother only admitted to some skin disease. This child came from uncomplicated pregnancy and delivery. His vaccination was up to date. And in fact, the first illness that he experienced as such was a bacterial bronchitis when he was 8 months of age. However, from 8 months onwards, he started experiencing very frequent respiratory tract infections, including bronchitis, middle ear infections, and sinusitis, which were mainly bacterial with encapsulated bacteria or presumed viral. At 1 year of age, he contracted a primary EBV, which was very complicated with prolonged fever. He had enlarged liver and spleen, which persisted way past the normal time of EBV clearance, and he also had persistent lymphadenopathy. At 4 years of age, he had to undergo tonsillectomy and adenectomy, and the tissue was so massive that it was even produced to the histologists and asked for an assessment, and they saw a massive but non-malignant lymphoproliferation. By 5 years of age, this child had chronic cough and developed mixed ventilatory impairment. He was sent to the pneumologist, and as you can see on these terrible X-ray and CT scans, he has multiple pathologies, such as atelectasias, bronchiectasis, some infiltrative changes, and also mediastinal and paratracheal lymphadenitis. And on the pictures or images from the and bronchial endoscopy, you could see that the tissue is not nice and smooth as it should be, but there are these bumps which are lymphonodular hyperplasia, or the proliferation of the mucosa-associated lymphatic tissue. By 5 years of age, he also was experiencing frequent episodes of abdominal discomfort, accompanied with chronic diarrhea. He still had enlarged liver and spleen with normal liver function tests and no explanation for these findings. He had mesenterial lymphadenopathy, and also on the GIT endoscopy, he had intestinal lymphonodular hyperplasia, just like it was seen in his bronchi. At this point, his white blood count was considered normal. He had mildly decreased IgG and decreased IgG2, for which he was referred to the immunologist. And as you know, as immunologists, we are an inquisitive bunch. And so we first mistrusted the patients in claiming that they are healthy. Well, the father was eventually considered healthy, but the mother, who was 30 years of age, not so much. Since childhood, she turned out to have frequent respiratory tract infections, including pneumonias, bronchitis, and sinusitis, all either bacterial or viral. She also had recurrent labial HSV. She also had to undergo tonsillectomy and adenectomy. Very untypically, at 12 years of age, she had a cervical lymph node excised to be examined for suspicion of being a malignant issue, but once again, this tissue showed non-malignant proliferation with predominantly CD3 cells expansion. And since 24 years of age, she did have a skin disease, but it was not something to be dismissed. She was in fact followed up by dermatologists and oncologists for suspicion of having cutaneous lymphoma. You can see the picture on the right hand side, which is an image of her right shoulder, where for several years now she kept having these infiltrative changes. She had multiple biopsies and all showed, again, non-malignant CD3 T-cell expansion. The conclusions were always non-malignant, but atypical. She also had a PET CT scan, which showed generalized lymphadenopathy and enlarged spleen. And when she came to us with her son at 30 years of age, she admitted to having chronic cough, and we found her to have structural lung damage with multiple bronchiectasis. So at this point, we performed the immunophenotyping, and as you can see, both the patient and the mother share some similarities. In the antibody compartments, we see a mild decrease of IgG in the patient, but IgG2 deficiency for both the patient and the mother, and there was a abrogated response to MMR vaccines and to the EBV infection, which both of the patient and the mother experienced. And in the cellular compartment, there was a decrease of CD19 cells in the patient, but a very marked increase in transitional B cells and decrease in class switch CD19 cells, indicative of some sort of maturation defect. In the T cell compartment, both the mother and the patient had depression of naive CD4 cells. So unsurprisingly, both of these patients turned out to have a PIK3CD mutation, which is one of the most common mutations, and it encodes for the PI3K catalytic subunit delta and constitutes diagnosis of APDS type 1. So the others after me will go much closer into much more detail in this, but just for what I will say or show in a minute, PI3K delta is a tethering enzyme specific to leukocytes that assist in the transmission of signals from growth factors, cytokines and hormones. And it acts via the PI3K delta ACT-mTOR pathway, and these mutations are effectively considered gain of function for APDS1 and in function also for APDS2. Even the mechanism is different, and what may be found, what may be seen in these patients is the increase in the phosphorylation of some of the proteins along this pathway, such as the ACT, as seen here in our patient and his mother, as compared to the controls on these phosphoflow charts. So the patient was offered immunoglobulin replacement therapy and antibiotic prophylaxis, which undoubtedly improved the frequency of his respiratory tract infections, but he continued with his lymphoproliferation. mTOR inhibitor was considered, but was not eventually given because of the availability of specific PI3K delta inhibitor, which he was on and has been on now for 17 months without any adverse events. And this inhibitor basically normalized the frequency of this patient's respiratory tract infections and markedly improved the control of his abnormal lymphoproliferation. The mother was offered IG replacement alone, which improved the cough and respiratory tract infections, and then shortly afterwards she was put on the PI3K delta inhibitor leniolisib 2, which also normalized the frequency of her respiratory tract infections. And as you can see on these two pictures, this was the first time since she was 24 years of age when the exacerbations on her shoulder with the skin T-cell infiltration stopped, and she was able to heal this with a scar. So here we had a visual indication of the control of her lymphoproliferation. In the Czech Republic, we follow 8 patients, 7 are APDS1 and 1 is APDS2. And in this cohort, we can nicely see a couple more important aspects of APDS, and this is the other risks that are associated with such a profound immunodysregulation that we see in the APDS patients. And these are the risk of autoimmunity. 4 of these patients have autoimmune complications, particularly thyroiditis, but also cytopenias are very common. Enteropathy may be an issue. hepatopathy and others. And one patient from our cohort also had Hodgkin lymphoma, which nicely demonstrates that patients with APDS are also at increased risk of having not only benign lymphoproliferation, but also malignant. This chart also nicely shows, if you look at the yellow arrows, that all of our patients' infection susceptibility was prominent before the age of 2 years, and the onset of lymphoproliferation for all of them was seen prior to 5th year of age. When looking at the immunophenotype of this small cohort, it very much reflects and aligns with the rest of the reported patients. There is a level of dysgammaglobulinemia, although the IgG may be normal, just like the IgA and IgM, and so the normality of immunoglobulins should not discourage the diagnosis of APDS if the other signs and symptoms fits. One of the hallmark features in immunologically is the increase of IgM and the problem with response to some vaccines, particularly pneumococcal vaccines. In the B cell compartment, we would typically see the decrease of CD19 B cells with increased pool of transitional B lymphocytes and decreased class switch lymphocytes. And in the T cell population, the typical finding would be decreased naive CD4 and sometimes CD8 cells with increased senescence of these T cells. So to summarize, this is a list of the most hallmark features of APDS. The frequencies I pulled out together for APDS 1 and 2. So the most common symptoms would be respiratory tract infections with risk of early lung damage, chronic benign lymphoproliferation, risk of herpetic infections, including HSV, EBV, CMV, etc., increased risk of autoimmunity, enteropathy, and malignancy, particularly lymphomas and leukemias, and also some neurodevelopmental abnormalities. This is particularly true for the APDS2. In the lab, we would see, may see the increased IgM, lower normal IgG, decreased CD19 and CD4 cells, and increased transitional B lymphocytes. For these features, when put together, some differential diagnoses come together. And in fact, some of the APDS patients were for a long time classed as some of these diagnoses shown here in the box, such as hyper IgM, ALPS, CVID, CID, or in fact, primary lymphoma. I have one more slide, which I am unable to move now. Okay, so we have already received some questions prior from the participants, and one of the questions was if there is a need to evaluate the affected patient's family. And to this question, I would definitely say yes. The tools we have would be the symptoms and history of the family and of the evaluated family members. We would have extended immunophenotyping. We would, of course, have genetics. We also have the PI3K delta and mTOR pathway components assessment. However, I would say that this would not be given a known mutation, which is already well associated with the PI3K delta defects necessary to perform for such patients. APDS is an autosomal dominant disease with relatively high penetrance and variable clinical severity, although there are some asymptomatic carriers described. These are not that very common. However, what is certain is that the treatment decreases mortality and morbidity, and the earlier the treatment is started for symptomatic patients, of course, the better. There is also the risk of malignancy as a primary manifestation of APDS, which then makes it very good for us to know who is and isn't a carrier of this mutation if there is an affected family member. And we could, of course, also use the services of our geneticists to provide genetic counseling to the affected families. So this would be all for me. And with that, I thank you for your attention, and I would pass on to the next speaker.
Yeah. Okay.
Okay. Good afternoon, everyone. So when we talk in this ESID Grand Round about PI3K signaling, we mean actually class 1 PI3K signaling, which cannot move on to the next slide. Here it is. So class 1 PI3 kinases are heterodimeric proteins consisting of a regulatory subunit, mainly called P85, and a catalytic subunit, as Marketa already described, which is called P110 for class 1A and class 1B PI3 kinases. So the class 1 PI3 kinases phosphorylate the third position of phosphatidylinositol 4,5-B phosphate to resulting in phosphatidylinositol 3,4,5-3 phosphate. The phosphatase P10 is the counterplayer of this reaction. PIP3 is an important second messenger in the cell and activates AKT and mTOR. Within this, next slide, please. Within this webinar, we are focusing on PI3 kinase delta, and there are different heterozygous gain-of-function mutations described, and the most frequent is the EMI-21K mutation. I cannot move the laser, so I don't have actually any. Yeah, so the EMI-21K variant. However, there are different mutations described all over which can affect different domains of the PIK3CD gene and P110 delta catalytic subunit. Next slide. So some of the domains are located within the catalytic subunit, but other mutations are interfering with the domains important for the interaction with the regulatory subunit, P85 alpha. And these variants, they cause a conformational disruption of the PI3K delta regulation. Heterozygous splice site mutation in the PIK3R1 gene encoding for the regulatory subunit of PI3K, the regulatory subunit P85 alpha, were described to cause APDS2, and these variants are splice site variants which lead to an novel aberrant splicing from splicing, and since since splicing from exon 10 to exon 11 is in frame, this results in a shortened P85 alpha protein, which you can see here. So as you see here, this shortened P85 alpha protein disrupts the conformational regulation of the P110 delta, and as such leads to APDS2. Another missense variant has been described, also laying within the P110, interfering with the P110 binding. All these different variants or mutations result in hyperactivated signaling, which can be monitored by phospho-AKT, as shown here, an example for APDS. Important is that it is so we in our lab, in my team, we are analyzing activated PI3 kinase cell delta signaling in T cell blasts from patients, and in these T cell blast cultures which were propagated with IL-2, you can see in a non-activated condition increased phospho-AKT levels, compared to the controls. And here, this is an example for the APDS. This increased AKT level can be inhibited using PI3 kinase delta specific inhibitors. And if you stimulate these cells with OCT3 cross-linking, so TCR receptor cross-linking, you see a strong induction of phospho-AKT. Similarly, for APDS2, you see an increased basal level without any activation. And then this is reversible with the PI3 kinase delta inhibitor. So the immunological consequences of increased PI3 kinase delta activity for T cell subsets are, as Marketa already described, decreased CD4 T cell counts, decreased naive T cell counts, especially of the recent thymic immigrant type. However, we frequently observed increased effector memory CD8 T cell frequencies in both types of APDS, APDS1 and APDS2. So these hyperactivated PI3 kinase delta signaling promotes CD8 terminal effector memories cells, which are long-lived and which frequently express CD57. Hyperactivated PI3 kinase delta signaling promotes also T follicular helper cells, and this can be seen by an increased frequency of circulating T follicular helper cells. And in lymph node biopsies, we can observe the hyperplasia of PD-1 positive T cells, as seen here, compared to the controls. PD-1 is expressed by TFH cells. On the B cell side, APDS1 and APDS2 have lower B cell counts. They show a decreased frequency of memory B cells and switch to memory B cells. However, an increased frequency of transitional B cells. IgM levels tend to be higher, whereas IgG and IgA tend to be low. How can we explain this? So PI3 kinase seems to play a role or plays a role in the bone marrow, and we find an increased frequency of late pre-B immature B cells in the bone marrow, with, which are CD10 positive. These transitional B cells are found in the blood. We see less IgD, IgM naive B cells, and that might be due to the fact that hyperactivated PI3 kinase delta signaling actually promotes plasmablast differentiation, short-lived plasmablasts, which tend to be increased in APDS patients, and which are probably responsible for this high frequency of IgM, which we can find in the serum of these type of patients. These plasmablasts tend to produce autoantibodies of the type IgL, but these are IgM autoantibodies. Immunoglobulin class recombination is disturbed, and I come to this point in a minute. So Ig class recombination is disturbed, and as such, we find less memory B cells, and we find less long-lived plasma cells in this patient. So as I said, class recombination is disturbed, and that is PI3 kinase actually regulates AAD. It shuts off AAD. So if you have hyperactive PI3 kinase delta signaling, you have actually it's shown to be decreased AAD levels. So, and AAD is important for the initiation of class recombination. So this is the physiological role of PI3K. But now if you use PI3 kinase delta inhibitors, or PI3 kinase delta inhibitors, you can actually normalize the AAD expression. But that has to be really nicely fine-tuned, because the risk is that increased or that PI3 kinase delta inhibition leads too strong PI3 kinase delta inhibition leads to increased AAD presence and potentially AAD mediated off-targets effect. And the publication showed that a slight increased mutation frequency in AAD off-targets, and that was analyzed in IFR4, PIM1, and PAX5 enhancer, have been observed in patients with CLL treated by idelalisib, a specific P110 delta inhibitor. So I would like to thank everyone, and sorry for the problems at the beginning of the seminar.
Good afternoon. Hello, my name is Anita Chandra, and I'll be telling you a bit about the treatment of APDS. These are my disclosures. And just as a reminder, although Margarita has already given you an overview of the clinical features, but the APDS 1 and 2 patients, they tend to predominantly present with lung disease, with pneumonias, recurrent infections, and bronchiectasis. They have evidence of lymphoproliferation, which ranges from benign lymphadenopathy affecting the bronchus and the gut, and anywhere, in fact, to hepatosplenomegaly, all the way through to malignant lymphoproliferation, with manifesting as a lymphoma. There's an increased risk of autoimmunity, such as autoimmune hemolytic anemia and ITP. And of course, because it's an immunodeficiency, there's increased risk of multiple different infections, including those with encapsulated bacteria and viruses in the herpes family. So given that they are the main clinical features, and the patients have a mixture of almost normal immunoglobulins, selective IgA deficiency, selective antibody deficiency, all the way through to a combined immunodeficiency, the treatment really needs to be targeted according to the symptoms and phenotype of the individual patient. So as it's an immunodeficiency, most patients are managed initially with antibiotic prophylaxis. The vast majority of patients who have an antibody deficiency are commenced on immunoglobulin replacement therapy, and that can be either subcutaneous or through the intravenous setting. As a major manifestation is respiratory tract infections, they really should be managed alongside a respiratory physician with some very bundle treatment options for chest disease, such as physiotherapy, the use of nebulized antibiotics, hypertonic saline nebulizers, and with very careful sputum surveillance and active treatment of any infections. As we related earlier, a lot of the patients have immune dysregulation with autoimmunity, and therefore they can be treated with steroids or calcineurin inhibitors or rituximab, as in the case of a lot of the patients with autoimmune cytopenias or vasculitis. As Sven has already alluded to in the pathway, the PI3 kinase delta pathway downstream is the mTOR pathway, and so certain number of patients have been treated with mTOR inhibitors such as rapamycin. As this disease leads to a combined immunodeficiency with quite a variable phenotype, those patients with a significant family history and severe phenotype can go on to have a stem cell transplantation. And finally, there is more targeted therapy that's available, such as PI3 kinase delta inhibitors. So I'll just go through those one by one in terms of what the APDS registry has in terms of data. So if we look from the initial paper by Makari et al. In 2018, you can see from a very early age, the vast majority are on immunoglobulin replacement therapy. And in this registry, there were 51 patients with APDS1 and 26 with APDS2. And as you can see, actually, there's a high incidence of bronchiectasis, hence the use of immunoglobulin replacement therapy. But what's important to note is that despite the use of immunoglobulin replacement therapy, a lot of patients still went on to develop bronchiectasis. You can also see here that a lot of the patients and the timeline at which they started on steroids or immunosuppressive drugs, and there's only a minority who have undergone a stem cell transplant. Going on to rapamycin, they showed in the registry that actually rapamycin is actually very useful for those patients who have evidence of lymphoproliferation. And we can see here that there are a large number of patients who have almost complete remission of their lymphadenopathy, or at least partial remission of their lymphadenopathy. What's important to mention here, though, however, is that when rapamycin is discontinued, the signs of lymphoproliferation do reoccur. And then going on to stem cell transplantation, there are two groups who have published on this. There's a Japanese group who looked at had 23 patients and transplanted 9 of their patients, of which 7 of the patients had good survival and improvement of symptoms. And the patients that they looked at, unfortunately, they had quite a significant event-free survival. Then going on to the ESID registry data again, they were looking at a mixture of APDS1 and APDS2 patients. And in this group of patients, there was quite a significant comorbidity. And in 26%, they had pre-existing hematological malignancy, and 86% were already on immunoglobulin replacement therapy. What they showed is that there was no difference in survival between APDS1 and 2. However, surprisingly, the prior use of mTOR inhibitors seemed to have associated with an increased risk of graft failure, and the pathogenesis of that is still eludes us. Despite there being a good overall survival, there were significant complications and lots of patients leading to poor graft failure-free survival. And 28% patients required an extra donor lymphocyte infusion. However, what was shown with those patients who did survive, that there was significant 96% reversal in their phenotype, and it was actually associated with a cure. And one unfortunate note is that the renal manifestations were not ameliorated despite the stem cell transplant. So overall, if we look at the 2 publications on APDS and the overall global incidence of APDS, about 13% of patients progressed to stem cell transplantation. And of those, over 70% are weaned off immunoglobulin replacement therapy at 100 days. There are complications in 90%, and there is significant mortality around 12%, with a good survival of 86%. So then we go on to PI3 kinase delta inhibitors. And the rationale against this is that this is a targeted approach where you have a small molecule that directly inhibits the production of PIK3 and downstream phosphorylation of AKT. Because it's more targeted, you would expect fewer off-target effects, therefore fewer side effects. It has the potential to be curative. However, the thing is, you need to give a lifelong therapy in order to maintain the effect of the drugs. And as some of you may have heard, there is this drug called leniolisib, which the Prague patients have already commenced on. Back in 2017, they started a part 1 study initially where they had a dose finding exploration where they gave only 6 patients a 12-week course of leniolisib. At that point, they identified that 70 milligrams twice a day was efficacious and safe. They then went on to a placebo-controlled 12-week study. And at the end of this, the placebo patients were allowed to enroll and cross over into leniolisib. And then they progressed onto an open label study in which all of the patients were offered leniolisib. Therefore, in total, in the open label study, which then went on for about a year, 38 patients were treated with 70 milligrams of leniolisib twice a day. And in terms of side effects, leniolisib was extremely well tolerated, had very minimal side effects. In fact, they're all usually around SAE type 1 and 2. So it was very, very well tolerated. And I'm presenting the data at the end of 1 year of treatment rather than just the open label study. And what that showed was that leniolisib was significantly associated with a reduction in lymphadenopathy, both in small lymphadenopathy and hepatosplenomegaly, as identified here in this CT. In terms of antibodies, it was associated with a reduction in the elevated, so basically normalization of the serum IgM. In terms of the cellular changes, there's an increase of naive B cells and a reduction in the numbers of transitional B cells. And as you know, transitional B cells elevated transitional B cells seems to be a pathognomonic marker for APDS. And then going on to T cells, the use of leniolisib was associated with a reduction in the senescent and exhausted T cells as marked by a PD-1 and a CD57. And what was also remarkable that in 27 of the patients, there was a reduction in the use of immunoglobulin and replacement therapy. And in actual fact, now of those patients who've been receiving it for a few years, 6 patients are completely free of the use of immunoglobulin therapy, and their immunophenotype has completely normalized. And this is some updated data from the ESID registry. So this is up to date as of 2022, and this was kindly given to me by Marie-Elena. And this just shows some up-to-date data about those patients who are on immunoglobulin replacement therapy, some steroids, rapamycin, rituximab. So we can see here only 8 patients in the ESID registry were actually given PI3 kinase delta inhibitor. I think a lot of those 38 patients were from the US, and they're not actually part of the ESID register. And in total, about 17% of patients in the registry have received a stem cell transplantation. So in conclusion, the APDS is due to hyperactive PI3 kinase delta signaling. Stem cell transplantation is potentially curative, but there is significant morbidity and mortality. PI3 kinase delta inhibitors of the selective kind, such as leniolisib, have huge potential in treatment of this group of patients. However, it requires chronic administration of the drug. It's got a highly targeted mechanism of action with a relatively benign safety profile. What we can see already is that for some of the patients, and it's early days because a lot of the patients have only been on it for a year, it can enable cessation of immunoglobulin replacement therapy. And what we can see is that there are few, if any, of non-immune complications. And I'm going to finish there, and I'll answer the questions from at the end once everyone else is finished. Thank you.
Hello, everybody, also from my side. I'm very happy to give you today an update on the ESID APDS registry on behalf of the registry investigators. So at the moment, we have 46 documenting centers and 171 patients who have APDS are registered in the ESID registry and also in the APDS sub-registry, and are also well documented with the level 3 clinical and immunological information. If you want to participate to the study, you need to be an ESID documenting center. You need to have a signed patient consent form, and you have to send to the principal investigators the registration form. And as you can see here on the right, since its start in 2015, the registry has been recruiting regularly and is actually still recruiting at the moment. And what you can see here is an example of the registration form you would need. And you can see that the main information needed are details regarding the mutation found in your patient. If you have questions regarding registration or participation to the study, I already put here my email address and also the one of Annette Ullmann, who is coordinating the study. We are preparing now a second publication on the registry data, which will be not only an update on the registry, but also a comparison with other similar autoimmune lymphoproliferative inborn errors of immunity, namely CTLA-4 insufficiency, NF-κB1 insufficiency, and recently published a big cohort of patients with STAT3 gain of function. And the 171 patients I just mentioned will be the patients analyzed in the manuscript, and only 68 of them have been published in the first publication of the registry in 2018. Starting from the genetics, you already heard about it in the registry. 2/3 of the patients have APDS1 and 1/3 as APDS2. And particularly interesting is that among the patients with APDS1, 90% of them have the one very most frequent mutation, and all patients with APDS2 have deleterious splice site mutations after exon 11, as Sven showed to you already. And this is particularly interesting because it's very different from the situation of the other three diseases we are comparing APDS2, and shows a rather low genetic heterogeneity of APDS. Regarding the initial presentation, you can see here on the left the age of onset of all the APDS patients in the registry, and the median age at onset is shown in blue and is very early. 1 year is the median age at onset and is the earliest. Maybe the closest is the STAT3 gain of function with the age at onset below 5 years, but NF-κB1 insufficiency and CTLA-4 insufficiency tend to start later in life. The initial presentation in APDS is dominated by infections, and I think you can appreciate how low is the frequency of patients who initially present only with immune dysregulation and no signs of recurrent infections. Talking about infectious complication, I think every physician treating APDS patients could confirm that the most important infectious problem are respiratory infections, but this is rather not specific to APDS and present also in the other diseases. What I want you to appreciate, however, is the chronic EBV and CMV infections are more relevant in APDS and in CTLA-4 than in the other two inborn error of immunity. And what's important to notice also is that opportunistic infections in general are overall rare, maybe most common in NF-κB1 insufficiency, but in general rare in all 4 diseases. Lung disease, as already been mentioned, is very relevant, especially under a clinical point of view. And here I want you to see that the diagnosis of interstitial lung disease is less frequent in APDS when compared, for example, to STAT3 gain of function or CTLA-4 insufficiency, where this diagnosis is much more frequent and also, of course, limiting also regarding the prognosis. What's more, an APDS thing is bronchiectasis, as you can see here, but again, this is not specific for APDS and possible also in the other 3 diseases. What emerges in the last period is the frequency of asthma in APDS, as recently also published by an American cohort. But again, this is possible also in CTLA-4 insufficiency and was unfortunately not assessed by the other 2 diseased analyzed. With hematological manifestations, I mean in this case not only chronic benign lymphoproliferation, which is not surprisingly common in all 4 diseases, but also cytopenia. And I think here it's interesting to see that cytopenia in APDS is actually less frequent than in the other diseases. And this is relevant, for example, if you think about CTLA-4 insufficiency, where cytopenia is not only more frequent, but also much more severe, being often one of the main reasons for transplant. And finally, with malignancy, I mean here not only lymphoma, but actually also other kind of malignancies. And although you can see that the frequency of malignancies in APDS and in NF-κB1 insufficiency here in red is similar, actually the age at cancer diagnosis in NF-κB1 is much higher than in APDS patients. Then endocrinological manifestations, they are emerging and as relevant for these kind of inborn errors of immunity with lymphoproliferation and immune dysregulation in general. And here you can see that, for example, thyroiditis is not so frequent, but possible in all 4 diseases. Growth impairment, and here I mean actually not only growth hormone deficiency, but growth impairment in general, which in these diseases can actually also be due, for example, to severe enteropathy, is a relevant problem both in APDS and in STAT3 gain of function. And for example, talking about type 1 diabetes, this is of course common in STAT3 gain of function patients, but not only, because at low frequency it's observed also in the other 3 diseases. With immune dysregulation includes enteropathy, which is present in all diseases. Maybe interesting is that autoimmune hepatitis is much more frequent in STAT3 gain of function than in the other diseases. With skin disease, it's meant mainly eczema in APDS, STAT3 gain of function, and CTLA-4 insufficiency. Whereas in patients with NF-κB1 insufficiency, other kinds of immune dysregulation of the skin have been reported, such as vitiligo or alopecia. And in general, in NF-κB1 insufficiency patients, skin infections are always more common than immune dysregulation of the skin. Renal disease is very interesting, is emerging. It's actually usually not so frequent as a sign of primary immunodeficiencies, but is present in at least 3 of the 4 diseases analyzed, and it seems to be always immune mediated regarding the pathogenesis. And then finally, neurological features, they are also frequently present in all the diseases, but I think it's important to mention that the features reported are very heterogeneous. For example, in APDS patients, the vast majority of the patients have neurodevelopmental delay, and inflammatory causes for neurological features are much less frequent. And this is, for example, not the case for CTLA-4 insufficiency, where lymphocytic infiltration in the CNS or consequences of severe cytopenia are the main causes for neurological features. In STAT3 gain of function, for example, thanks to the large cohort recently published, we know that epilepsy and stroke, so vascular insults, play a big role. And finally, in NF-κB1 insufficiency, the range of neurological features reported is very broad, ranging from peripheral neuropathy to PML reported in the patients. So we already talked a lot also about immunological abnormalities in APDS. What I want you to take home from this slide is I think that there is no immunological abnormality which is specific of one disease or the other, and there are many which are possible in actually all 4 of them. And for example, also hyper-IgM, which is rather typical for APDS, is reported in the registry in 31% of the patients. And increased transitional B cells, which yes, are reported frequently in APDS patients, can be, however, found also in NF-κB1 patients. And that's true also for CD8, CD57 positive T cells, which are increased in many APDS patients, but also in STAT3 gain of function. And the same could be said, for example, regarding increase in double negative T cells, which can be found in STAT3 gain of function, but also in CTLA-4 insufficiency, and has been reported also in APDS patients, although this parameter is not assessed, unfortunately, by the registry data. And what I also want to mention is that it was very interesting to see that in the STAT3 gain of function cohort and NF-κB1 cohort, a correlation between some immunological abnormalities and clinical features could be made. for example, between reduced CD4 cells and viral infections, or increase in CD21 low B cells and autoimmunity. But until now, we could not reproduce such associations in the APDS cohort, maybe because the quality of the immunological data is not as good as the one of the clinical data. So Anita already talked to you about treatment in APDS. So in the last few minutes, I have thought about talking to you about our attempt at defining the severe disease in these patients. So we defined patients with severe disease if they had a severe infection plus immune dysregulation signs, excluding chronic benign lymphoproliferation and cytopenia, or if they had chronic lung disease or a severe form of immune dysregulation or malignancies, or if they had already one sign of severe disease and had been registered in the registry very early in life, so that we had a very small window of observation of the patient. And using these criteria we chose, of course, it's important to highlight, we defined 93 patients with a severe disease course, with a median age at reaching this severity of 9.5 years. And here you can see practically the same information on a graph. You can find on the x-axis the years and on the y-axis the age of the patients. The blue dots represent the age at onset, or the year at onset. In red, you can see the severity, so the age or the year at reaching severity of the disease. And then in black, you can see the death, the age at death. And important to mention is that all patients who deceased had a severe disease course, which could be reached with a median age of 6 years between the reaching of severity and the age or year of death. And here, interesting to see is the relation between the probability of having a severe disease plotted against the age on the left and against years since disease onset on the right. And what you can see is that although, of course, this evaluation has to be corrected because we deal mainly with retrospective data and we have a small window of observation of the patients, what you can see is that the risk for developing a severe disease actually accelerates with the age. And of course, what we wanted to do and what we tried to do is to find risk factors or predictors for a severe disease course. And what I can tell you is that gender and the genetic type of APDS, meaning APDS 1 versus APDS 2, actually does not play a role in the development of a severe disease course. And that's true also for hypogammaglobulinemia and also for the presence of immune dysregulation directly at the beginning, so directly at initial clinical presentation. They are both not associated with a severe disease course. What's associated with the severe disease course is a very early age at onset, below 1 year of age. And what I also checked is if the diagnostic delay played a role, meaning the years between the onset of the disease and the clinical diagnosis of an inborn error of immunity. And this diagnostic delay actually did not play a role in developing a severe disease course. And this is true also for patients who were clinically diagnosed before the 2015, meaning before the genetic cause of the disease was actually known. So the preliminary conclusions we reach is that there is a large clinical and immunological overlap between APDS and the other autoimmune lymphoproliferative primary immunodeficiency, that APDS is clinically characterized by very early onset and frequent respiratory infections, and I highlighted that bronchiectasis and early onset lymphoma are rather typical for APDS, but not specific. I showed to you that the genetic homogeneity, which is typical for APDS, does not actually reduce the heterogeneity, which we can find clinically and immunologically. And according to our criteria for a severe disease course, 55% of the patients suffer from a severe disease course, and they are classified as severe before the age of 10 in more or less half of the cases. And the only risk factor we could identify until now for a severe disease course is the very early age at onset of the disease. I thank you very much for the attention, but before I finish my presentation, I really want to stress that the APDS registry can be seen also as a tool. So if you have an idea about an interesting project using the data of the APDS registry, you can write a short proposal, and one page is actually more than enough. You can send it to the lead investigators, and I put their email address here. And we can then perform a feasibility check, meaning we can see if with the registry data we can actually answer the question you would have, and then you can actually start your project. So if you are interested, do not hesitate to contact us. And with that, I would like to thank you for your attention. I'm happy to take questions.
Okay. So thank you very much. Thank you all the speakers for all their lectures. I really believe it gave us the complex view on the disease, and it actually answered a lot of questions we have received before the ground rounds. They concern genetics and diagnostics and therapy. So I think that we have some kind of idea, and I would now concentrate on questions that are coming here. So thank the audience for sending us the questions. So I think we will start from the beginning, and I will read the question. The first one came early in the seminar and asked, does linear ESID or mTOR inhibitor reduce the risk of malignancy? As I said, it's probably a lot to you, Anita, because you have the clinic, so probably you can start.
I don't think we have had enough patients who've been treated for a long time. We need that kind of data. Really won't be available for another probably 15, 20 years. I mean, one can speculate, given that the immune phenotype is normalized and the PIK3 levels are normalized, but that's speculation. We really just have to wait, and that's really important why the patient should be registered. Then we can actually do the long-term follow-up of these patients.
Mm-hmm. Thank you very much. Then we have another one. Would particular mutations affect the efficacy of linear ESID-mediated PI3K delta inhibition? So I do not know exactly if it comes from the registry. You were talking about the mutation and clinical phenotype correlation, but this question is about the linear ESID treatment. Can you probably answer that, Maria or Anita or Stefan?
So the target, the pocket that leniolisib inhibits, the binding site, is actually, it theoretically shouldn't matter where the mutation lies in P110 delta. So far, the patients that have been treated are those who are predominantly E1021K and the E525K, I think, if that's correct. The vast majority of patients are, though, E1021K, so it would be interesting to note whether any of the other patients with the other mutations would be treated effectively. Theoretically, that it should be all treated. It should inhibit all of them.
Yeah. Okay, even before and even here, we have some question concerning specific antibody response. If they are treated with linear ESID, does it improve? Or even if the patient has normal levels of IgG, should we consider the replacement to somehow replace the specific antibody response?
So we haven't got the data yet about leniolisib and the specific vaccine responses, for example. That's being undertaken at present, and that wasn't part of the trial, so that's sort of led by each individual clinician. But certainly that data will be coming in the next few months, if not year.
There is another question. If we should really, if immune replacement therapy is necessary in cases of normal immunoglobulin levels. So maybe Anita and Marketa can also comment on that.
So I would argue, do they, how many patients have completely normal immunoglobulins? Because even those with normal total IgG often have IgG2 subclass deficiency and a selective antibody deficiency. And given the incidence of bronchiectasis, I would strongly support the starting immunoglobulins early on. I know that a lot of patients still go on to get bronchiectasis despite immunoglobulin therapy, but at least that's immunoglobulin and antibiotics, or at least some form of treatment rather than just observation.
I totally agree. And the knowledge that some patients do develop bronchiectasis should not discourage us from offering the immunoglobulin replacement.
Yeah. And maybe I can also add to that, during the renal treatment, we observe that we can reduce or maybe sometimes even withdraw the IgG replacement because it somehow correlates the dysregulation and this IgG production is getting back to almost normal. Yeah. Okay, so this is a set of questions about this therapy, and I will try to move to the next one. Yes, and maybe it's even for Sven. We also got this question. It's about the diagnosis and about actually the functional test. If we should evaluate ACT phosphorylation to monitor the efficacy or to somehow confirm diagnosis.
I think for efficacy, it's more difficult on a normal basis. I think it was done in the clinical trials, but for normal labs, I think it's not a good idea because it's a really difficult evaluation. For novel mutations, to be sure that there are functional consequences, I think we need phospho-AKT analysis, yes. And we should also always, for potential novel mutations, investigate the inheritance, if possible. It will tell us a lot.
Yeah. I actually agree. I think it is not widely available, the ACT phosphorylation assay in all the centers to get it. So we should probably stick to these markers, which somehow came up from the case reports and from the presentation. I think that all this combination of early start and about all these typical laboratory low IgG2 and high IgM and all these abnormalities in B cells, they just put together the picture quite well. I do not know if you agree.
Well, I'm a bit skeptic. As Maria Elena has shown, many of these other autoimmune proliferative diseases have similar immune signatures, which are in part overlapping. I agree that there are some that really stand out in PDS, but still I would be careful in regarding them as unique. So in any case, I think a genetic diagnosis is needed, and I think there are frequent surprises.
Yeah, I agree. Some other comments on this diagnosis? So if not, we have another quite interesting question, which I do not know what to tell. Can we monitor the treatment response with T follicular helper cells?
I don't think they actually recorded the T follicular helper cell phenotype because that's not routinely offered. I mean, that's more even in the trials. I don't think they recorded that.
Yeah. Okay, we have a question also from Bodo. I also do not know about T follicular helper cells. Sometimes we have to look at it. And Bodo asks, do you have an idea what influences the phenotypic expressivity? So maybe for Stefan or for Maria Elena, I do not know exactly. I think it was really very nice to see the registry, as the number of patients is quite big, so it's much better to come to some conclusions, but I do not know the answer to this question.
Yes, we have not tried yet to do a retrospective correlation between a certain pattern of manifestation and, for example, age at onset or sex or a particular mutation, APDS 1, 2. I think it would be an interesting exercise to use certain patterns of manifestation and try to understand whether there are correlations. But in any case, I think the power of the registry is limited to really answer this question. It would probably need more experimental approaches.
Yeah. Okay, thanks. So there's another question concerning lymphoproliferation and imaging. So it reads, what imaging follow-up would you recommend for APDS patient to look for lymphoproliferation when there is no clinical or blood warning sign? Somebody?
Well, I think in the UK, most patients have a baseline imaging. And then I would say it's your clinical instincts if they've got weight loss or any type of lymphoproliferation. And then I would suggest at least a basic CT, but preferably a PET-CT.
Yeah.
I also differ if we're talking about adult screening or children's screening. We're usually a little bit reserved in terms of invasive procedures or radiologic procedures if the children are not showing adequate signs of disease as such. Then I'm not sure as a pediatrician in children with few symptoms or no symptoms of lymphoproliferation, if I would go for like a whole body PET scan, for example, that would probably be a no from me.
And maybe if I could add, just always remember that in these patients, a positive PET-CT does not mean immediately lymphoma, because if you have the suspicion, you have to confirm it histological.
It's very, very true.
Okay. And we have another quite specific questions. Are there any splenectomized patients due to hypersplenism? I am not aware of any. Did somebody, you do not have this question in the registry, right? About this.
I think in the very, very old patients which were clinically diagnosed before the genetic diagnosis of APDS, there were some splenectomy, but I think it's not very frequent, maybe.
Yeah.
We actually do have the information in the registry, and it's rarely, but it's performed, usually because of cytopenia, actually.
Mm-hmm.
And
okay, it again shows the power of the registry.
Yes.
The information on more
and what's also, sorry if I interrupt, what's also very frequent, and I think it confirms the experience that physicians have, is tonsillectomy. I think almost all of them received that, and in the end received the suspicion of lymphoma, for example, as Markita explained.
That's true, yeah. Okay, a lot of questions. Another question is about double negative T cell population. Have they been studied in APDS patients?
Yes, there are some publications available which show that double negative T cells can be increased also in APDS patients, but the registry unfortunately does not assess this information. So that's a sign of not power of the registry, but it's there, it's out there, published, that it's possible.
Mm-hmm. And another question goes back to genetics. What is the penetrance of E1021K mutation?
Maybe Sven can answer better than me. I think an important information here is that in the registry, we have very few asymptomatic individuals. But this can also be the fact that it is a registry done by a physician treating the patients who then are referred to them for some clinical complaints. That could be a bias. So I can actually not give the real information regarding how many asymptomatic individuals are out there. I think one thing we added to the registry in order to be able to improve this information is to add information regarding segregation analysis. I think the example of Markita was wonderful. The mom said, yeah, healthy, but in the end it was not. So we try now to add this information in the registry regarding the new patients, if the parents were also screened for the mutation, but I don't know actually how many asymptomatic individuals are out there.
I think with all the incomplete knowledge that we have at the moment, we can say that similar case collections for STAT3 or gain of function or CTLA4 deficiency show, examples of 20 to 30% of patients who have very few or even no symptoms. And this is not the case for APDS, which may in part be due to the genetic homogeneity, but it may also be due to the particular disease pathophysiology. So I think what we know so far, penetrance is really relatively high.
Okay, thanks. So the next question somehow directs us back to the clinics and ask an important question, I think, when to start a therapy in patients who are currently asymptomatic. So we are asking this question quite frequently with children, which we diagnose in families. So what is your opinion?
Marketa, do you want to answer for the children?
Okay, so I would first be, at first I would always be very mistrustful in the asymptomatic. So I would ask both, the parents and records from the general pediatricians. I have only received symptomatic patients and quite severely symptomatic of those. So I haven't had experience with pre-symptomatic children at all. If there is if there is an immunophenotype suggested of immunoglobulin deficiency, I would start on the immunoglobulins, and I would wait with the other treatments for the development of any clinical symptoms or any suggestions as where to this particular disease in this particular child would take him, because as we know, there are asymptomatic children, although not patients, although not that many. I have even found a case, this may be interesting to you, there was a published case from 2020 on a child who was diagnosed with APDS1 through a newborn screening with very low TREX. And it went on to be found out that both the child and the mother, who was over 30 years of age, asymptomatic still, have the same mutation. And now the intuitive approach was, if the child has low TREX, then it must be one of the more severe phenotypes. It's going to have highly dysregulated. There will be the T cell disturbance, and but alas, no. For the year that the child has been reported for to be known to have APDS or to be as such not symptomatic. So this is an interesting case to demonstrate that we know more. We need more information, and we can't generalize yet on this subject.
Yeah, just now I do not know if we have still time for the question, but I would be glad to at least answer something about transplantation. There are a bunch of questions about transplantation, and the most important is how to and when to indicate this therapy, before any treatment or after treatment, or consider it when there is some proliferation or even lymphoma. So maybe, Anita, you can answer that.
I think it's very dependent on the patient, on the age, and on the severity. I know that the paediatricians in the UK are they really consider transplantation as early as possible before the child has any significant disease. From the adult perspective, I think if certainly if there's a family history and the delta inhibitors weren't available, that and they had limited comorbidity, we would consider transplantation. I think what leniolisib now promises to us is that it has the potential to be a bridge, so you have a bit of time for those patients, whether you consider should they have a transplant or not. And maybe those patients who are on it long term, you'll be able to determine whether it's curative and whether they will need a transplantation indeed at all.
So thank you very much. You know, I am somehow pressed to stop the discussion here because we have still these registry meetings. So I will do that. Thank you again very much all for your presentation. And I think it really gave us the picture of the disease. Please, all attendants whose questions were not answered, we apologize and answer them individually. Thank you very much. And I probably pass the word to Stefan. You will probably direct the APDS registry, right?
Yes, thank you, Anna. This is really, everyone can stay if they wish. We just want to make a few internal remarks about the registry, what is going on at the moment, and how we see the perspective. And for this, I will hand over to Annette Uhlmann first.
Yeah, thank you very much. Thank you to all who are still online. We want to start a short APDS registry investigator meeting, or so-called business meeting. I'm Annette Uhlmann. I'm the project manager for the registry. And so I want to start with some formal or administrative topics, and then hand over again to Stefan and the other ones. Can I click? I'm free to forward. Thank you. At first, one word to the lead investigators of the registry. Maria Elena already introduced the heads. And since 2015, when the registry started, there was Stefan Ehl, Sven Kracker, and Alison Contliffe, who moved this registry forward, who developed the protocol and the online registry level 3 questionnaires. And next, please. Or can I do it by myself? No, it doesn't work. Yes. This year, Alison handed over her role to Anita. We have met her the whole evening. And I think, I'm not sure if Alison still is participating or if she has participated. I think she has left the hospital. She has been retired. And now Anita will play her role in the United Kingdom. And next, please. We say thank you to Alison for her great efforts to this registry, for the motivation of the UK sites, and welcome to Anita, and we are looking forward to the cooperation. Next, yeah. A quick view on the status of the documentation. There are, I think with today, we have 200 patients registered. That's a very old number from Friday. And as Maria Elena mentioned, we have nearly from all patients the documentation of the visit 1, the so-called retrospective data. But you can see in this graphic, I don't know if you can see my cursor, the number of visits documented. These are nearly all for visit 1, but only 50% are complete. This is the orange, and the gray one are the not complete documented visits. And further on, you can see the documentation status of the follow-up visits. It is planned. Next, please. Yeah, it is planned that every year, one follow-up visit should be documented, and you see that the quantity and the quality as well are decreasing with the time. And so we urgently ask you and your study sites to keep up with the documentation. You have seen now that there is really somebody works with all these data, and that we need the data to learn more about this disease, and last but not least, to treat your patients. Next. Just to keep in mind how you can document the APDS patients, a quick glance into the online ESID registry. You find the APDS data in the section studies, and if you click it, you have to enter the APDS specific patient ID that's in addition to the ESID registry ID. And this APDS ID you find on the evaluation form. We return to you after you have sent a registration form to us. With this number, you can start the APDS documentation. Next, please. But you have to complete, before the APDS documentation can start, you have to complete all forms of the level 1 sections. That means each of these sections have to be ticked, and then you can open the APDS study documentation and proceed. And next. And please also keep in mind that before you can start the documentation of the first follow-up visit, you have to complete the visit 1 documentation, and so on with the further follow-up visits. Next. Yes, and there is a small benefit for you, apart from that you have nice data for analysis and for publications. There is a case payment available, thanks to the funding of pharma industry. We can pay €100 for the complete documentation of the first visit, and €50 for each follow-up visit, 1 per year, and another €100 for the completion of the transplant documentation. The conditions for the payment: we pay out 1 time per year. The patient must sign the new GDPR compliant consent. The documentation of the respective visit has to be complete, level 1 and level 3. That means all tabs ticked. And you need a valid APDS investigator agreement between your site and ESID. That's in addition to the normal ESID documentation agreement. And then all is ready for the payment. Next. But yes, I think that's it. Now I hand over back to Stefan, who will explain the next challenges for the registry.
Yes, thank you, Annette. I think you have noticed during the presentations that there are a lot of open questions still. They concern therapy, but they also concern questions about lymphoma, for example, about the transplant indication. And all of these questions are essentially long-term questions that require us to move the registry forward, not only for a year or two, but for at least the next 10 years to get meaningful information. And I think we're quite lucky to have had support from pharmaceutical industry. It used to be UCB and GSK and Novartis in the beginning, and now it's Pharming, who have provided us with these exciting opportunities of the PI3 kinase inhibitors, which are very promising drugs. But I think in order to learn more about this, we need to learn more even beyond the clinical studies. So the registry will be a key tool for a collaborative effort between ESID and the pharmaceutical industry to generate data that are really important in the follow-up of the use of these drugs. And so efforts are ongoing at the moment to adapt the registry, to incorporate some of these industry needs, to use the registry as a post-marketing surveillance instrument, which will generate data in the future. So next slide, please. So this is one of the major areas that we will look at. And there have also been, I think, very interesting study proposals to the registry. And as Maria Elena mentioned, we are very open to receive additional proposals. So to really look into every corner of this disease that is meaningful for patients. So one project has been initiated by Olaf Neth and Peter Olbrich in Sevilla on growth in APDS. And they want to look into treatment and response to therapy and also diagnostic evaluation of patients with growth deficiency. There is an idea to look closer at renal disease and APDS, and we are currently looking at a study feasibility together with Romain Lévy in Paris. And also a question came up about B-cell recovery after rituximab in this disease. And again, we are looking at feasibility at the moment. So again, I would like to encourage you to phrase your questions and then to address them to the registry. Next slide. Yes, and I think that's all from our side, from the registry. And I don't know, Anna, I don't know whether you had a look at the chat, whether there's any additional question in relation to the registry now at the moment.
Actually, chat is here, but I do not see new questions about the registry. No.
Okay, excellent. That's fine then. I think then also from our side, I think we have made the major points, and I think I would like to thank, in the name of the steering committee, really Maria Elena for her efforts in putting this together and being for the last years the study physician who was really most engaged in analyzing the data. And I look forward to all the future collaborations within ESID for this registry. So thank you.
Thank you. I think it's really great because it is such a rare disease, and 200 patients is really great cohort. So congratulations to the registry. Okay, so thank you everyone. Again, I think it was very nice meeting, and we are looking forward to the next ESID Grand Round. Thank you.
Bye.
Bye.
Thank you.